Hello and welcome to our review of the lupus literature from May. We're recording these podcasts for you every month, so you'll always be able to kept up to date on the latest literature and expert opinions. I'm Ed Vitale, I'm chair of the Lupus Forum. I work in the University of Leeds, and I'm joined today by Professor Brad Rovin, Professor of Nephrology and Medical Director of the Ohio State University Clinical Research Management Institute. Welcome, Brad.
Thanks, Ed. It's a real pleasure to be back on this podcast with you.
Yeah, likewise. So we've looked at key papers that have come out in May. There's just two that we've selected for discussion today, both touching on some pretty important clinical themes, and both using data from kind of real world situations, which I think is quite nice. So the first one of those is one about glucocorticoid tapering on belimumab. So this is belimumab corticosteroid tape sparing treatment in SLE, a real-life observational study. So this is a French study from multiple real-world lupus centers, and it's about how when belimumab is used in real world, are people able to taper to target doses of prednisone? So we've talked about this quite a bit on the forum in the past, the concept of treat to target in lupus. For example, to LLDAS, which needs SLESIS-R 4 or less, and prednisolone 7.5 milligrams or less. DORIS, remission, where the prednisolone target is 5 milligrams or less. And EULAR also recommend a kind of bit of both of those, so kind of LLDAS, but with prednisolone dose less than 5. I think so we're encouraged to try and hit these targets because of data showing that maintaining these low disease activity, low steroid states is associated with better long-term outcomes in terms of things like quality of life, mortality, damage, etc. I think there could be a little bit of debate about the causality of all of that, whether some people just hit their targets all the time because they've got mild SLE and they were destined to do well, and some people never hit their targets because they're just more severe SLE, and we're not completely sure how hard we should try to increase therapy to hit all these targets. And I'll come back to that a bit later on, but it's probably true. So there's some evidence, and I think this is something we reviewed in a podcast in the recent months, that there is a clinically meaningful difference between maintaining prednisolone doses at 7.5 or at 5, that there is something measurable that goes on between those two levels. Although I actually saw an abstract that's going to be presented at EULAR next week that was a bit against that. Anyway, so what happens in this study? So we know already from the RCTs that belimumab is steroid sparing, but RCTs aren't real life. The patient populations who get into these trials they need certain characteristics, like disease that's reasonably stable to get them to screening and be able to consent to an arm that has a placebo in it. Mostly skin and joint disease. Some other organs can get excluded, like neuropsychiatric, etc., etc. So they aren't real life, and this here is real life, which is always valuable. So these are patients who just received belimumab as part of their routine care. They checked medical records of 38 patients between the centers. 30 of them had enough data, i.e. at least 6 months data, to contribute. The analysis here is pretty simple. It's all descriptive. Of those patients, 93% of them were on steroids at baseline, the median dose of 10, IQR 7 to 20. 40% of them are on what they call low dose, which they mean 7.5, and 20% were on very low dose, meaning 5. Belimumab's generally coming in as a fourth-line agent here, probably just due to their local prescribing characteristics. So these, in other words, anti-malarial, steroids, at least one immunosuppressant. During the follow-up period, 7 patients came off therapy, 5 due to inefficacy and 1 due to adverse events. The others are all continuing. Fairly low dropout rate, I would say. And they saw significant reductions in steroids at the 3-month, 6 months, and 12 months time point. So from that baseline median of 10, we're going 8.5 at 3 months, 6.75 at 6 months, and 5 at 12 months. 6 months in, about 60% of the patients were on low or very low doses. Majority of those were on very low or none. And 12 months in, that have gone up to 80%, the majority on very low or none. No real renal disease to speak of here, because of the criteria for prescribing the drug at the time. And a big limitation that the authors describe is because the sample size isn't that big, they're not really able to look at things like subsets or other factors that might be influencing the reduction here. So yeah, I thought it's a nice bit of real world data that touches on some important themes, is a relatively small study, relatively simple in its description. It does tell us that these targets in these patients who are relatively resistant and mostly on prednisone at unacceptable doses can achieve the targets more than 50% of the time, which I think is a useful piece of information. I guess one of the things I thought was a limitation was that because this is all people on belimumab who failed other agents, but we don't have a control, e.g., how much steroid reduction could you get if you took a group of unselected people starting azathioprine or mycophenolate for the first time, for instance, because that would help us answer that question, that if you're kind of like in the situation of needing your first either immunosuppressant or biologic, are we saying that you're better off going with belimumab because you'll get more steroid taper? Or is it actually equal between conventional immunosuppressants and belimumab? So I think that would be it'd be useful to have that information as well. And then the other thing, like I say, I was thinking about the treat to target thing and how causal is all of this. In other words, if we've got people who are not quite on target, is hammering away with more and more immunosuppressants, switching them, changing them all the time, doing everything we can, going to get them on target more often and improve those long-term outcomes like damage and mortality. It makes sense, but that hasn't actually been shown. Everything's correlative at the moment, and it might just be that people who are going to do well. And there is a trial in progress that's being run in Germany by Matthias Schneider and Johanna Muck that is trying to answer that question. So I thought that nice bit of context for this. What did you think about this one?
So I was a little bit unhappy, not understanding why the patients were being put on the belimumab. It was a very small cohort, and we really didn't get the descriptors of why this needed to be a fourth line drug and what was the resistance. The other thing that, of course, from my point of view, I would have liked to have seen more renal patients in the mix, because as everyone knows, we tend to use a lot of steroids in patients with lupus nephritis, and my goal is to try and get patients off. The final thing that I thought was interesting, and I was wondering what you thought, is at time 0, when they started the belimumab, a lot of the patients already were on the low dose or very low dose.
Yeah.
And what I was hoping for was by the end of 24 months that we would see more patients coming completely off prednisone, because ultimately that's my goal anyway. So I'm still a little bit curious as to how I would use belimumab as a steroid sparing drug in my own practice. I guess this whets my appetite for further investigation, as you've sort of indicated, with a little bit more detail.
Yeah, I think that's right. Yeah, so it looks like it's about 25% end up off steroids completely by the end of the study. I suppose one issue there is we don't know, I don't think, that these physicians were deliberately following a treat to target strategy, like really trying as much as they could to get steroids, do we?
Yes.
And we know there's a difference between individuals in how they prep, your attitude to steroids, actually from both the doctor and the patient. There are some patients who just say, I'd rather stay on my 5 and keep out of trouble. I'll take the risk or whatever. So yeah, you don't know if it was more aggressively targeted, more would have come off, etc. there are center effects with steroids as well, aren't there?
Absolutely. And
Yeah.
I do know patients who want to stay on their steroid,
Yeah.
which amazes me. But nonetheless, I try to get that as absolutely as low as possible and see what we can do with the patient. But interesting trial.
Okay, let's go on to the next one.
All right, so this also will talk a little bit about steroids. The next one is the SLESIS-R, an improved score for prediction of serious infection in patients with systemic lupus erythematosus based on the Rensselaer prospective cohort. So this study is trying to ask a very important question. Can we predict patients who have lupus that we're going to treat or are undergoing treatment and who are going to develop a serious infection? And I think, some of this might be a little bit intuitive, but it's nice to have some objective data or an objective scoring system to work with. And what these investigators did, which I thought was very well done, was they initially wanted to create a score, and they did, called the SLESIS, to look at this question of prediction of serious infection in lupus patients. And they did this using the Rensselaer cohort, which is a cohort from lots of institutions in Spain, that was a retrospective cohort. And they developed a score, and then they validated it with another retrospective cohort out of the UK. And what they found was only a modest degree of prediction with the score, with an area under the ROC curve of a little over 0.6. And they were unhappy with those sort of test parameters. And so they went back to the Rensselaer cohort and now looked at the prospective trial and redid this entire index. And they started out with about 1,459 patients and looked at who developed a serious infection and who did not prospectively. And I think that's the key. And when they did this, they had a number of variables, both clinical, demographic, and the various SLE damage indices that were significant between the patients who developed infection and the patients who did not. One caveat here, or two caveats really, is demographically almost all of these patients were white. And the second caveat is that only 25 patients of the entire 1459 developed infection. But regardless, they took these significant scores, significant parameters, and then they put them together in a multivariable index, and they peeled off data or predictors that were repetitive or redundant. And what they finally got down to was a very efficient 4-variable model that they could use to predict infection, serious infection in patients undergoing treatment for lupus. And what the model boiled down to in terms of the 4 predictors was age, greater than or equal to 60, whether or not you've ever had a previous lupus-related hospitalization, and whether or not you've ever had a previous serious infection. And then glucocorticoid dose was part of the mix, and the glucocorticoid dose ranged from lowish doses, as we were just discussing in the other paper, all the way up to 30 or more, which gave a high score. And the idea was that if the score of these parameters added up to greater than or equal to 6, you were at a very high risk for infection. And when they did the test of this, they actually did an internal bootstrap validation, and they found that the sensitivity was 76% and the specificity was 86%, with an accuracy of 86% in predicting people who actually would develop infection. And the area under the ROC curve was over 0.8. So they actually developed a very reliable scoring system. Now, the internal validation is good, but what we really want to do is see this in an external cohort. And of course, from my point of view as a nephrologist, I was surprised that the fact that the kidney disease, which was part of the original set of variables to distinguish patients who became infected or did not become infected, actually dropped out in the end, which was curious because patients with chronic kidney disease really are predisposed, as we all know, to infection. But the other variables were more important. So that was quite interesting to me as a nephrologist. What I'd love to see, and Ed, I'd love your opinion on this, I want to see this really spread out to a population that would include patients with African ancestry, because they often have very severe lupus, as well as higher incidence of kidney involvement that can be quite problematic. So that would be one thing I would like to see this go forward on. What are your thoughts, Ed?
Yeah, I liked this. Yeah, I think I thought methodologically I liked the approach. It's one of those papers that just made sense when you're sort of reading how they made these decisions and how they'd done it. And I like the fact that when you look at the score, like it's on the slide now, you just see, okay, I just give these points to these, you could totally see how you could pretty much do it in the clinic, in a few seconds and identify your high risk person. Things, yeah, again, things I'd like to see, like you said, I think, the cohort's pretty big, but the serious infection number wasn't that large, which did make me wonder if did something like kidney involvement fall out of the score just because it wasn't represented enough. It's easy for me to say do a bigger study. They already had 1,500 patients,
Yeah.
but 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 you do wonder, don't you, whether you'd get something a bit different. Then again, do the steroid dose criteria pick up all the renal patients, and that's why the steroids is kept in and the renal isn't, for example.
I really think this would be fun. So in my lupus clinic, of course, it focuses on patients with kidney disease. And so what I would like to do is bring this forward to myself and the other folks in the
Yeah.
clinic, and just use it and see how this works out in terms of how our patients develop, sort of get another real world view, since we're talking real world data.
I was thinking that too, because the
Yeah.
variables they've chosen are quite simple. The outcome of serious infection is reliably extracted from medical records, usually, because it involves hospitalization. So actually, there could be many cohorts where they could do further replication or exploration of these different subgroups. I kind of thought the type of treatment that's being chosen might be important.
Well, they had, which was really interesting, cyclophosphamide was one of the predictor variables in the univariate analysis, and that fell out.
Yeah.
So I thought that was very interesting.
Yeah.
Mycophenolate was in there too, and that fell out.
Oh,
So
yeah, and this brings me to one of the other things I thought about this, because I mean, there's one thing which I'm always banging on about, is that we always say, doctors and patients, everyone says these drugs are immunosuppressants, they can increase your risk of infection. But most of the time, when that's looked at, it isn't really borne out. There's a lot of RCTs where the treatment arms have lower infection rates than the placebo arms. Um, and it doesn't always, and I think the reason is, one is the lupus disease process itself gives you infection. Having low lymphocytes and no complement is not good. And if you can improve that, it's better. And then the other thing is, of course, these agents lower your requirement for steroids, which are probably a higher risk drug than a more targeted immunosuppressant. So
exactly. We keep coming back to the same thing, which is the need to get rid of steroids or
yeah.
reduce the dose as much as possible. I absolutely agree. And in our other kidney diseases that are not lupus that we have been treating with high dose steroids, the infection is generally when the steroids are at the peak.
And the lupus is crazy active.
Yes.
I'm saying, I mean, I literally wrote to one of my patients last week to emphasize this point because I thought it was so important. Was like, don't assume, don't assume that these immunosuppressants that you're worried about are going to increase your risk of infection. It might be the other way around. The best
Well,
thing I can do for your infections is make you well.
don't you think it's amazing that we add a third drug like a calcineurin inhibitor or belimumab to two other drugs that are really quite potent, and we really didn't see a huge increase in
Yeah, yeah,
infections
yeah.
in the randomized trials. I'm stunned by that. And
Yeah, that's right. That's right. And it's all about efficacy. So,
yeah,
and then the other thing I thought about this paper, just reflecting on how it might impact practices, I was like, well, so if I see somebody in my clinic this week who comes up with a super high score on this, what am I actually going to do? And I thought, well, I'll try and taper the steroids a bit more, maybe. I might try and add in other drugs that I know have lower infection risks, like we said, like rituximab, for example, in my clinic. Maybe I'll push a bit more on protective things like vaccinations, perhaps. Yeah, what
when
modify closely.
yeah, when I thought about that, I really, what caught my eye, and of course, intrinsically, this, the older age group really makes a difference. And that was something I think, we need to watch these folks a little bit more carefully. And I think it does push me towards what I've been heading toward anyway, which is starting out with lower dose, even in patients with lupus nephritis, and using some of these more targeted therapies to, for example, substitute. We've used a lot of calcineurin inhibitor now with the approval of voclosporin, for example, and as you recall, that was a very aggressive steroid taper,
Yeah,
uh, and that's something that I really liked.
yeah. Great. So I think that's all we've got time for today. So thanks for joining me, Brad. It's always great to hear your thoughts. And we'll catch up at ULAR next week.
It'll be my pleasure, and love doing these podcasts.
And thanks everyone for listening. As always, full slide decks are on lupus-forum.com, free to access as always, all the content free to download. Download the PowerPoints and use them in your own teaching or your journal clubs as you wish to. And if you register for updates, then you'll get an email every time there's something new coming out, or follow us on Lupus Forum, all one word, on Twitter or LinkedIn. Thanks again, and see you next time.
Bye bye.